Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD and the Life's Best Medicine podcast. This guy is so great that he has to go on both. I don't want to waste 2 hours of his life trying to get him interviewed on both podcasts, but I will tell you, he's had a massive influence on me and my career choice of going into direct primary care and self-help and really being able to help people from a metabolic standpoint. He's been a spearhead on this. He was the first one I heard talking about food addiction and carbohydrate addiction. He's trained with Tim Noakes. He is the addiction doc. Rob Cywes, welcome, doc. Great to have you,
Brian.
man.
I mean, you know that you are one of my heroes in the space, and I know it sounds like mutual accolades, but it's absolutely true. Not only in the way you practice and the passion you bring and the knowledge you bring to each individual patient, which we need to talk about, but also as a human being, your contribution. You know, you just keep it quiet. You're going to Guatemala to do some mission type work. Who you are as a human being just reflects what you do in practice, and that rubs off on your patients. And I'm thrilled and honored to be part of this. Thank you.
Yeah, you say that, and then when you do question and answer, you rip me apart on my talk, man. What are you talking about, Rob? No, Rob, you're the best, man. When I see you, I go, okay. If you say something different than I'm saying, I'm like, I better reassess what I'm looking at because you've been solid. You've been right on. And I will tell you, your April Fool's joke was the best I've ever seen. I think I had a Zoom meeting with my patients last night, and I said, "How many of you saw Rob's thing about the earrings?" And 4 people raised their hand and started laughing right away because they're like they were trying to order it right now. But that shows the even I was watching, I was fooled because I'm like, my gosh, Rob, if Rob's looking at this and they've researched it, it's got to be legit because he's not going to put it out there because I know your character. So, that was just anyone who hasn't seen it, go to YouTube and watch his April Fool's joke. I mean, it's pretty amazing. Great job, man.
Well, thank you, Brian. But, as I reflected on doing that, I had a lot of fun doing that. One of the people in my office found this ridiculous advertisement for earrings that get you to lose weight. And that was about a week or two before. And we just blew it up in the office. And then I said, hey, why not reflect on this and do it as an April Fool's joke? But there's some very important understanding, and this particularly applies to our audience that is very much online, that are biohackers, that are looking to the online community because we've been failed by the conventional healthcare system. And here's a problem. If you take, and this is what I did with this video. First of all, I was very pan-faced. I didn't laugh or smile, but if you take some medical truths, some absolutely true facts, you can then blow that up into a wonderful fictitious story that is completely embellished and completely false, but so believable because there are kernels of truth to the science. And all you need is a slick snake oil salesman to sell that to you. And, Brian, in my office, I don't ask people what medication, are you on any medication or are you taking supplements? I ask them what medication are you on and what supplements you're taking, because everybody almost is on something. There are very, very few patients that say, I don't take anything. And then why the hell don't you take anything? This is America. You should be. And the point is that the majority of the supplements our patients take are unregulated, unproven, untested, and they have this beautiful story attached to them that is so plausible, they spend their money. I call it a wallet biopsy, where somebody with a slick story is biopsying money out of your wallet. And if you look at the number of people who are so desperate and so easily bamboozled and fooled into wanting to buy earrings that magically get you to lose weight without changing anything, that was just such a reflection on what our society's become. And there's an additional, even worse situation with all these chatbots where a computer or an AI algorithm can now write absolute nonsense in such a believable way that it'll represent what we're doing. So we are entering a very, very dangerous era where the internet, computers, AI can completely fabricate something and get us to buy into it and take humanity down a pathway that it shouldn't go down. That's the first comment. The second comment is it also gives us some insight into how easy it is for pharmaceutical companies, for other people out there with agendas to sell drugs, with agendas to legitimize false facts, such as the statin industry, and to be able to convince people, starting with Ansel Keys in the 1950s onward, that the lipid heart hypothesis is so good that you shouldn't be eating fat, you should be eating a lot of carbohydrates. So that is the battleground. The battleground is not that they're trying to con us, certain people are, but the battleground is really how naive and how easily we allow the wool to be pulled over our eyes. And that's what this video exposed. So we really, the message of all of this diatribe is be very, very cautious. Be very cautious of who you believe and what you buy and purchase on the internet, because most of it is Bernie Madoff magic.
Yeah, and that's the problem. And the big thing is there's respected people out there, or I'll tell you, this is just one thing I noticed, and some of the newer diabetes meds that we're talking about, the injectables, and people are losing weight and they're doing it. But what I noticed is there was a group of about 10 influencers, doctors that attacked Jason Fung on the same day, and I'm like, this is odd. Like, it just struck me as odd. Like, they're saying he's a clown. Fasting doesn't mean, and I get it. I mean, he has a different perspective than some people do. But the point is, they were totally mocking him and attacking him. And then 4 days later, I noticed all these same people were promoting the new diet drug that was being injected, saying, hey, just do this. Now these same people are saying, hey, $99 a month, and I'll write you a prescription for this as long as you want it. And so it's a business model, and they're not talking about lifestyle change. They're just saying, hey, we'll inject you with this drug, and it's like your earrings. You magically put these on and you lose weight, and you don't have to do anything, and it's easy. And you can still eat your cookies every night. So that's totally irresponsible, and it's malpractice, in my opinion.
I agree so much. Let's explore that, because it's so important and we need to put it in its place. So the first comment about what you and I do for a living is what we try to do is make people metabolically healthy. And when you are healthy, you really don't need drugs or supplements. That's the whole purpose. You and I de-prescribe more often than we prescribe. And so we are in the reduction thing. And the biggest problem with the ketogenic or low carb space is it's a space where we can't really sell product to make things better, because it's about relatively hard work and investing in yourself and changing fundamentally who you are as a human being, both behaviorally and nutritionally, to make yourself healthier and better. And therefore, it is the reduction in purchasable crap on the internet rather than buying some magic bullet. So we kind of are the opposite of what the internet is doing, trying to make money off vulnerable us and selling us stuff. Now, in terms of the GLP-1, so my practice philosophy is based on a pyramid. At the foundation of the pyramid are three very easy or very easy to understand, difficult to do concepts. The first concept, and each one of them is a trade-out. The first one is get rid of carbohydrates in your diet and replace them primarily with fat, preferably animal fat, but with fat and protein that comes along for the ride. So it's reduction in carbohydrate consumption, increase and comfort with eating fat and protein. The second concept, and along what you were saying with Jason Fung, is getting rid of snacks, because a snack is always, always, always an emotional event. It is never a nutrition event.
Yeah, you screwed me with that one, by the way.
That's such an important concept. I mean, you see both of us are drinking our coffee or whatever it is, which is a bridge. But the point is that whether you use the word fasting or just not eating, the way the human body works, it works in a cycle. There's a period of time, for a short period of time during and after a meal, where you're storing what you've eaten, and then long periods of time in the day where you're utilizing what you've eaten. So, but if you're eating all the time, you're in storage mode all the time, and that overwhelms the system, the ebb and flow of the system. And, can you imagine, you live in California right now, if it's high tide all the time, that's a problem. But the snack is the mental part. So the first one is getting rid of the carbohydrates, replacing with fat and protein, and obviously other foods that we eat. Getting rid of the snack, replacing with a bridge, which still gives us that mental health, mind cleansing moment without the caloric harm of what we're eating. The third component, the third behavioral component, and you cannot outsource this. We can give advice, you and I, Brian, but we cannot, no patient can outsource this. This is something we have to do as human beings. So the third component is to build up a healthy, effective, diverse emotion management system that involves the creative arts, involves physical activity, involves human connection, involves spirituality, meditation, so that you are developing an internally generated emotion management system rather than externally consumptive emotion management system. And that's the foundation, by the way, in which we practice. And once you do those three things from a mental health and a biologically health perspective, you are going to be the healthiest human being you can be, irrespective of where you started out. However, that is something that every individual has to do by themselves as a behavioral change. For some of us, including myself, it is a very, very difficult challenge to do by itself. So along the way, we add in things that give us the ability to initiate or sustain that process. So for example, if you've tried to quit smoking many times, every doctor is going to offer you Chantix or Nicorette gum, or if you're an opioid addict, every doctor is going to say at some point, if you relapse many times, here's some Suboxone, here's some methadone. We don't deprive our patients and say, no, you've got to cold turkey this, get off the heroin by yourself. I'm not going to, because those are tools we use to help us. The GLP-1s, and here's the stress, the important thing. The GLP-1s, as you so correctly said, erroneously are being advertised by Weight Watchers, who's just bought a company for $1.3 billion that's a doc in the box, by Calibrate, by all these companies that are writing scripts. As long as your BMI is over 27, a doc in the box will write the script, off you go, you pay some money for this drug. It is singular therapy that gets you to lose weight, but it doesn't change why you became fat in the first place. And then as soon as you can't afford the medication, as soon as you come off, and all their studies show this, it's called the STEP trials on Ozempic, 4 of them, they all show massive weight regain and return of diabetes as soon as you come off, because you haven't fundamentally changed who you are. So we will, in our practice, use GLP-1s as for a short period of time to help people to get on track a little faster. If they're struggling, if they've crashed and burned, I use it as a rescue tool. But it should not be the foundation of therapy. It should be an addition to an already foundational part of your change. It's exactly the same way that I use bariatric surgery. For some people who are really putting the effort in, but they have excess weight to lose and they're just struggling, we can add certain devices and surgery in, but not as an alternative. So in our practice like ours, I think these things have value, but as part of multimodal therapy, as part of rebuilding the human being, not as an outsourced monotherapy. And the time will come, everybody's excited, from the Kardashians down, everybody, look, I'm losing weight. But every new diet, everybody gets excited. Oh, I'm on this diet, I'm on this diet, I'm on this diet. And look, I'm losing weight, I'm losing weight. But then a year, 2 years later, when all that fades and you start to gain back, oh, this diet didn't work. No, that doesn't work. Or this, and we start blaming the diet or the drug or whatever else it is.
Or you say I have to go back on that repeatedly over and over and over again, right? Because I keep gaining weight when I go off it, so I have to go back on it, and you're spending all this money. Now you're a hostage because you have less muscle mass and way more fat tissue out there, and that's a disaster. So, you know, and I'll say, Rob, as a little commercial for you, is I have a patient recently. He flew from California to Florida to get surgery with you, stayed in Florida for all that time. And the reason is because he knows you're going to do the post-op care. Anyone could do the surgery. That's not that you're, you know, that tons of people you've taught and trained, but the post-op care, because we know after you get a bariatric surgery, depression goes up, suicidality, divorce rate goes up. All these disasters happen when your life should be getting better because you've never fixed the underlying problem of food addiction or carb addiction, right?
Exactly right. And, you know, 85% of bariatric surgeries fail, not immediately. They all work very well in terms of weight loss, because that's what they're designed to do. They're designed to get people to lose weight and be healthy for a little while, just like diets. Diets are not there to change behavior. They're there to drop weight, caloric reduction diets. But if you don't change the behavior, as you said, the recidivism is high. So 85% of bariatric surgeries fail metabolically and by weight regain over 5 to 7 years. The STEP trials will tell you that close to 90%, I can't remember the exact percentage, but it's over 90% of people regain some or all of their weight back within the first year of coming off these GLP-1 agonists. And we're going to see this wave of people that have blown a bunch of money and have regained the weight because it hasn't changed them metabolically. Instead of eating the whole pizza, now I'm eating one slice of pizza. Well, what people don't understand is that may cause weight loss, but it doesn't really fundamentally affect the health issues. So your heart's not getting better, your thyroid disease, your Hashimoto's is not getting better, your PCOS is not getting better because you're not changing the behaviors. And that is the tragedy of where we currently are. I'll give you another parallel, Brian, which is something I just put out in a video the other day. My wife works in the cardiology space as a vendor in the cardiology space. And she went to the American Cardiology Conference in New Orleans a few weeks ago, and she's Carb Addiction Mom on YouTube, it's on Instagram. And so she's very attuned to low-fat diets that the cardiologists talk about, and then the low carbohydrate diets that her husband and lifestyle that she and our son follow. So when she was sitting at this meeting, she went to all the discussions around carbohydrates, around blood sugar, and around keto. And here's an interesting paradigm that the cardiologists are doing. They are starting to recognize, although they fundamentally, most of them believe in lipid heart, that fat clogs the vessels and that's a bad thing. And they believe that LDL causes damage to the vessels. They also, you can't unsee this, they've also understood that the commonest association with heart disease is diabetes and chronically elevated blood sugar. The problem is that is irreconcilable with their lipid heart hypothesis, that it's high fat that causes heart disease, that all the patients with heart disease have high blood sugar. But it boggles the mind. So then we say to them, okay, the ketogenic diet is the best way to lower your blood sugar. But they will say that appropriately so, that the ketogenic diet raises LDL. We know that's absolutely true. It makes all the other markers better, but your LDL goes up, and they believe that LDL causes cardiovascular damage. So because of that one fact, they discount all the benefit of keto or low carb, and they toss that out the window. However, they know that euglycemia, normal blood sugar, is critical to prevent ongoing cardiovascular disease. But keto, which is the best form of that, they've tossed it out the window because of LDL. So what they're doing now is they're prescribing more and more diabetic medications to maintain a normal blood sugar. The SGLT2 inhibitors, the Jardiances, the Farxigas, some of the sulfonylureas, and now the GLP-1s, because they maintain relatively good blood sugar and don't rise the LDL quite as much.
And a lot of these drugs make you pee out the extra sugar and stabilize the insulin. That's what's crazy. Your LDL goes up on those drugs, by the way, right?
It does go up a little bit, but not like it does on keto. And then they'll prescribe a statin because your LDL went up. So they're managing, their ideology is reasonable, that euglycemia is important, but the way they're managing it is outsourcing that to drugs rather than helping the person to change their behavior. And that is something. So this is the conundrum.
And while you're on that, Rob, the other thing I would say is when people go on a statin drug, we see an elevation of insulin and sugar as the byproduct of that. So I would say, look, cardiologists, if you want to put someone on a statin drug and you're insisting on that, okay, we get it. You're afraid of that. But tell them to do a low carb diet so that they're not having high insulin, high sugar, which we know for a fact is a huge the biggest cardiac risk factor. So you say, well, let's just give you this drug, but you don't have to change what you're doing. You can still eat all the crappy food you're eating, but we'll give you some drugs and we feel better and you feel better, but you still die at the same time.
In fact, it's not you can eat they encourage you to eat the crap, all the whole grains, the high carbohydrates, healthy fruit, stay away from red meat, stay away from meat, maybe have some fish on a Friday. So they're actually creating disease and then using medication to try to stop what they're creating. It's like telling an alcoholic, here, drink this bottle of whiskey and take this pill that keeps you sober so you can drive. That is lunacy, and yet that's what they're doing because they're still locked into this fear of LDL and cholesterol. So it's the conundrum that they face. And I want people to understand that because more and more these cardiologists are going to focus on drugs that reduce blood sugar. And everyone's worried about their blood sugar, but the only way to reduce blood sugar is to not put crap in your mouth, not to put the carbohydrates in your mouth, because once it's in there, the human body is obligated to deal with it. And those carbohydrates are going to cause damage somewhere. Well, for the cardiologist, it's not going to be the bloodstream because they bring that blood sugar down, but it's going to affect the cells. And elevated sugar levels inside of cells result in weight gain, results in an increased risk of autoimmune disease, an increased risk of cancer. an increased risk of dementia and an increased risk of PCOS in our women. So, and as you said, now you put them on a statin drug, so their dementia risk goes up significantly, their cognitive impairment, 7 to 11% increase in the diagnosis of diabetes just because of a statin. Forget about the leg cramps and the gastroparesis. So these are not innocuous drugs that they're using. I've had 3 patients go to the ICU because they were on SGLT2 inhibitors and they went into diabetic ketoacidosis on a ketogenic diet. So this is not innocuous. There's dangers associated with this. And I would use the word malpractice.
Yeah, I would agree with you. When I look at that, you put your patients at major risk and you go, okay, if we could just, instead of giving you a drug to make you pee out the extra sugar that can cause urinary infection, kidney infections, all this, why don't we just not put the extra sugar in your mouth and see what happens? And people do better and they don't need a drug that costs them, $800 a month. So there's so much of that where it's frustrating because it seems like we're playing shell games, right? If I shoot you up with a bunch of insulin and I shove all your sugar into your fat cells, into your brain, into your heart, into your kidneys, and go, look, your sugars are better. It's like, yeah, but it doesn't disappear. People think these drugs make the sugar disappear. You have to deal with that energy problem at some point. With the injectables that we're having now, yeah, if the appetite goes down and you're eating, like you said, using it as a bridge to get you on track, because a lot of what you were saying earlier, and you and I have a different temperament on things. You're a hardcore dude, man. You go, look, if your insulin's above this level, you're going to die. You got to, and so, or zero tolerance for carbs. And it's really interesting because there's some people who, like, if we set the bar too high, they go, forget, I'm not even trying. If you go, hey, if you want sourdough bread once a month and you can do that and you don't go crazy, but your testimony and your story of saying, look, if there's M&Ms in the house, I'm going to eat them. I'll rip the doors off stuff to get to it. And so people have to know themselves too. And that's why it's so important for us to have this continuity of care where we're monitoring the sugars and looking at, hey, what happened on Wednesday? Oh my gosh, my husband brought home donuts and I couldn't stop eating them and I ate 10 of them that night. That happens. We see those things. And that's the power of monitoring and getting to know the person as an individual. The biggest problem I see, and you and I see, we talked about it in healthcare, is this whole, you have this huge machine and this person's seeing a different doctor every time. They got 8 minutes with the patients. And how are they going to tell them, hey, let's work on diet? Because the most cost-effective thing for a doctor to do is go, here's a prescription, here's a prescription, here's a prescription. You got all these problems, here you go. Instead of stepping back, someone like you who's looked at the big picture. That's why I'm changing the name of my company from Low Carb MD to, San Diego Metabolic Health and Arizona Metabolic Health, because it's about the metabolic health. You taught me a lot of saying, hey, look, if you're stressed intense, and at that time in my life, I was working 18-hour days, stressed out, running around like an idiot, not sleeping. I go, this can't have a good effect on me, So your talk on dopamine fasting really changed my life because it made me reassess and go, wait a minute, what am I doing? And the other thing is all these doctors are in a system where they're basically slaves to the system. They're a cog in the wheel, and they're saying you're going to see more, you're going to produce more widgets. Instead of doing 5 a day, now you're going to do 30 a day. And you can't do the same quality of work. So I think it's a big, big systemic problem we have.
You've hit the nail on the head, and this is such an important topic to discuss because conventional healthcare has shifted away from being a profession to being a business. And the docs are no longer in control of what they do. They've become players in a big system that is really geared. I don't want to go all the money, and I don't want to point fingers at everything, but healthcare has changed into a business. And the problem with a business, and there are a couple of different issues here, is number one, individual doctors who are highly trained, who spend years and years, decades becoming what we are, there's not enough of us to be able to do the work that we do. So we have a number of other workers working in the space that maybe have 1 or 2 or 3 years worth of training. And you cannot in 1 or 2 years train somebody to understand physiology, pathophysiology, the pathway of disease. So the way they've managed the breadth of healthcare workers and employed healthcare workers, where you shorten the time and so you can do multiple consults, and you shorten or lessen the amount of medical thinking that people are trained to do over decades, because it is an art form. It isn't just a science. So what happens there is we no longer get to know our patients as individuals. And the way they've accommodated to that is to create what I call a best practice algorithm. So the majority of people out there practicing conventional medicine have an algorithm that they require every patient to fit. So it doesn't matter if you come in because you've got PCOS or obesity or diabetes. This is our algorithm. We're going to do the blood work. This is abnormal. Here's a pill for you. And they no longer go back to root cause. And you cannot do that if you don't know the individual patient. What you and I have done more so than anything else, it isn't about low carb or metabolic health. What you and I have chosen to do is to have longer visits with our patients, see fewer patients on a day, so that we get to know the patients as individuals. So I can meet the patient where they are and help them forward from that point, rather than trying to plug them into my algorithm. You go to a cardiologist, they're going to say, okay, here's your blood pressure medication, here you are, here's this, best practice. And they are unable to listen to you as a patient. And if you're on a diet that they don't prescribe, that's the wrong diet. It's not that they are agreeing or disagreeing with it. You just don't fit the algorithm of a DASH diet or a Mediterranean diet. And everybody has to conform to that. Everybody has to be on a statin. So the concept of algorithm medicine is the problem. And you and I have opted out of that to be able to individually treat our patients as individual human beings. I spend the first significant portion of a consult just trying to figure out medically and socially who is in front of me and where they currently are, what are their specific needs. The second part, I give them feedback on my ideology of where I think they are. Very often it's where they've come to me for those answers, but sometimes I see things in patients that they may not see themselves. So where you made maybe a little bit of an error in terms of assessing what I do, yes, we deal with, if you're 300 pounds, you've lost the capacity to control your relationship with carbohydrates. If you're an out of control type 2 diabetic, you're the equivalent of an alcoholic. But if you're an athlete who has been misguided to be eating a lot of carbohydrates, or if you're a well-balanced, I hate that word, a well-adjusted person who has just migrated toward the standard American diet, but you don't have the psychopathology, I'm going to treat you very differently to someone that I'm looking to get rid of stuff. But no alcoholic, there is no alcoholic who can drink safely. However, there are plenty of people who abuse alcohol from time to time who can manage that with boundaries. This is no different. There are some people who can manage their relationship with carbohydrates just fine. There are other people who can never, I'm one of those, I can never manage my relationship with carbohydrates and maintain that, because once I cross a threshold of permission, I'm lost. I can't stop. And it's 6 months before I sober up again. So I understand that about me, but I'm different in that way to other people. What carbohydrates do in me as a human being is the same for every human being, or very, very similar. However, your relationship with them, and this is the key thing, Brian, carbohydrates are not the problem. Carbohydrates are just fine to eat. The problem is our relationship with carbohydrates, and my relationship with carbohydrates is broken. So a large part of the discussion I have early on with my patients is to evaluate whether or not that relationship is broken, and then how to manage that relationship. So, and there are certain criteria that define, if you've had 5 DUIs and you've got liver disease, you don't have a good relationship with alcohol. If you've had 1 DUI, that might have been a mistake. And we can manage that. That's abuse, but it may or may not be addiction. We're going to figure that out. So
yeah, and that's what I love about you, is looking at that and then saying, okay, when you get rid of that snack, what are you going to fill that with? What are you going to do? Do you do volunteer work? Do you do knitting? Do you do sewing? Do you go to church? How do you fill that time? Because one of the biggest enemies to weight loss or fasting or whatever we're doing is downtime. If you're sitting there with yourself and you go, oh, I'm bored. Oh, what's on TV? Oh, look, they're advertising every 3 minutes, every commercial break, they're going to have French fries and Coke on there, right? Basically, and terrible foods. So it's amazing the mindset of this stuff. And that's what I love about you is the same thing. We have to assess that one patient, because I have some patients who go, look, if I can never eat sourdough bread again, I'm never doing this. But if they go, if I can have 1 piece a month and I'm happy with that, can I do that? Yeah, if you can do that. But like, some people can't just have 1 drink and they can't just have 1 cookie. They have one and they need that dopamine rush. And the other thing, Rob, I'll say is that you were one of the first guys when we started talking about carb addiction. I know at episode number 10 and number 13 of Low Carb MD, man, we got attacked by the doctors out there saying addiction has nothing to do with food. And it's amazing what we're seeing clinically is when people start getting their food in order, then all of a sudden they go, yeah, I don't really need to drink as much. I don't need to smoke as much. And all these other things I was doing that were maladaptive, I don't really need those anymore because they feel even and calm, right? If you're a stress eater and you take the stress away, what happens? You don't eat as much. And like Jason and I were just talking about, if
Brian,
you're getting a massage, you don't stop to eat something in the middle. You say, okay, this feels good. I feel great right now. I'm not getting up to eat a cookie.
Yeah. And, we can take that thing that people are obsessed about, the sourdough or the rice. And what I tell them is I say, look, the way you eat an elephant is one bite at a time. If you try to eat the whole elephant, you're going to choke, you're going to die. So if we start with the obvious things that are easy to give up, most often it's the sugar or the calories in our drinks, and you migrate away from that. And you focus on what you are going to eat. The worst thing about diets, and this is what I hate about anything with the word diet in it, by definition, the D in diet stands for deprivation. And if you feel deprived of something, if you desperately want something but you're not allowed to have it, it's just a question of time before you have it. If you develop a sense of arrogance that, look at all the good that's happened to me, and over time, not immediately, but over time, you develop a level of disdain for that sourdough bread or for the rice, you're going to give it up automatically. So we don't start with the thing you're most attached to. We start with the easy things. And as you start to, and here's the thing, as your self-esteem, your self-confidence, and your self-respect starts to grow, you're not going to do those harmful things to yourself. Addiction is also defined by a very poor sense of self, where we have to outsource the things that build up our sense of well-being. If you can develop a sense of well-being from within, you don't need external people to validate you, and you don't need drugs to get you high. But it's an evolving process. So it's a journey that we take our patients on. And the key thing that I try to develop with my patients is a relationship. A lot of my patients come in, they're already doing this. Oh, I'm doing great. I'm in the first year. I'm keto. I've lost weight. And all I want to see is my blood work. And they come in, they have their blood work, and then they're embarrassed to come back because they crashed and burned a year or two later. Nobody quits any addiction the first time. We're all very cocky and arrogant. I've got this. You crumple up the cigarettes, you throw them away, and then life happens. You're a little bit bored. You go on a vacation. You have a cigarette. Now you're smoking again. With greater humility, but greater experience, you quit and quit and quit over again until there's a last time. So the key thing is that our management philosophy is never deprivational. It is primarily empowering. We have to empower our patients to change because they have to see the need and the desire to change. So it's never deprivation. You're not allowed to do this. I've chosen not to do this. You can have ice cream any day you want to. I've chosen not to do that. The second part, and you mentioned this, is that everything that causes you harm originally had a beneficial purpose. That alcohol, that vape, that cigarette, that ice cream cone, it all had benefit, but the harm over time supersedes the benefit. So when you remove something, it leaves a void that needs to be replaced. Now, us in the ketogenic diet space have done a great job of nutrition replacement. But the other aspect that most people still don't get is the tremendous emotional value of a snack and of a carbohydrate high. And if you remove those carbohydrates, you're leaving a massive emotional void. And the primary reason people relapse is not on a nutritional basis. It's on an emotion management basis. They get stressed, they get anxious, they get depressed, they get angry, they're bored, as you said, they're having fun, and they give themselves permission to go back to carbohydrates, and they can't stop. So the emotion management side is as important in terms of replacement, filling that void, as it is to use carbohydrates. Most of my patients, when they have significant metabolic disease, if I open the emotion management toolkit, there's basically carbohydrates and cobwebs. Well, you remove the carbohydrates, what the hell are they going to do when granny dies or when they go on a vacation? The other key thing also, Brian, that's important just as a statement here is you go where you go. You go where you go. If you sit down in front of the TV, you're going to find some crap to watch. If you go outside, you're going to find something to do. It doesn't matter if it's a walk or you're going to potter around, you're going to check things out. The goal here is to put yourself in a position, in terms of the recovery from carb addiction, to put yourself in a position where you allow your mind to imagine a possibility. But you've got to be out there. If you're sitting in front of a screen, you're going to watch some crap or something good, but you're still going to watch something on that screen. You go outside, you're going to find something to do. So have those to-do things around you, see them. If there's a half-built puzzle on my dining room table, I'm going to walk past there, not every time, but sometimes, and put a piece of puzzle, sit and put a piece of puzzle in that paper, which prevents me from that walk of shame to the fridge. What can I eat? And if there's nothing harmful to eat or drink in the fridge, then even if I do get there and open it, my decision is, do I want a Diet Coke? Do I want some coffee? Do I want some water? Not, do I want some orange juice, or do I want some Coke, or do I want, some form of crystal meth? So the empowerment here is behavioral change, not just diet.
Yeah. And people, as time goes, like one of my favorite patients, she's crushed it. And I look at her, like she came to me the first time and sat down and goes, look, is it a deal breaker for you if I have sourdough bread every once in a while, or if I have, she owns a bunch of wineries up in Northern California, or if I have a glass of wine here and there? It's like, if you don't have a trouble with it, you can stop. It's going to slow your progress, but so anyways, I said, it's funny because just like you're cheating on me, we haven't even started dating yet, and you're asking me if you could cheat on me, right? And so I said, why do you have that mindset? And she said, well, I've done like the whole 30, I've done this and this and this. She goes, I can do anything. I can eat glass for 30 days. Day 31, I go back to my old ways and binge on everything I couldn't eat. So she said, just knowing I can have it. I was like, yeah. And so the first week she comes back and her sugars are all over the place. And I go, oh my gosh, but it was all from exercise, Orange Theory, working out. She didn't have any sourdough bread. I go, it was a big deal for you to have the sourdough bread. She goes, I look at it and go, is it going to help my situation? Do I really want it? I don't want it. And I make the decision I don't want it, not saying you telling me I can't do it. And so for her, that mindset, she's crushed it. Absolutely. But it was her mindset of saying, hey, I don't need it right now, maybe next time, right? Type thing. But if you say you can't have it, then you think about it all the time and it dwells on it. So certain people, but other people, if they have the addiction, the bigger addiction component, that one sourdough bread, and then they go off for a week, right? Or a month or a year or whatever it is. So it's amazing. But sometimes what I'm getting at is, once you pass it by a couple times, you don't have it, go, look, I didn't have sourdough bread at dinner and I survived dinner still, and I really enjoyed my time. And you realize, oh, I don't have to have that association with the sourdough bread. Like one thing that you said that really impacted me was like, hey, Brian, what's your favorite donut? Glazed. Okay, so you get your donut, you've been waiting all year to get this, and you drop it in a pile of dog crap. Are you going to pick it up and eat it? No, you look at it, you see it for what it is. And I think once people see it for what they are, sometimes when people go off on a binge for a weekend, the anniversary or whatever, they feel like garbage and their joints hurt and they're depressed and they're hungry all the time. They go, okay, I don't want that. So sometimes having that relapse helps people to say, okay, now I know how much better I feel when I'm not eating that way, and it loses its hold over you.
You're absolutely right. And I think to summarize what you've said, and this is the greatest challenge of people that work in our space. Because we're still, and there's a one-word transition. And if you as a patient and as a provider can make this one-word transition in terms of the conceptualization of what we're trying to change, that's the Holy Grail. And the word is this: when you want to eat sourdough bread, and when you tell people, no, you mustn't eat sourdough bread, the dietary word is changing what you're eating. So every dietitian tells you what you should and what you should not eat. What. The transformation to the addiction space, to the behavioral space, is a one-word transition. And that word is why. And when you ask yourself, why do I need the sourdough bread right now? Why do I need this right now? What is the purpose of this? And once you start answering the question why and challenge yourself with that question, you're going to make up your own answers. I'm not going to tell that person, don't eat the sourdough bread. I'm going to tell them, look, the sourdough bread is loaded with carbohydrates. It's your choice. And you can then answer the why. And the most empowering thing we can do is to help people to connect with the why. Why do I need this right now? Because carbohydrate addiction is not about the substance. It's not about the carbohydrates. As I've said, it's about our relationship with it. And once you answer the why, that's empowering. And when you have the self-esteem to say, that's disgusting, why the hell am I going to harm myself with that? You're going to stay away. If you have desire for it, you're screwed. And that's why what fails, but why ultimately is successful over time.
And also knowing your why. Why am I doing this? What are my goals? What is this going to help me towards that goal or not? Of getting off insulin, because a lot of people want to they go, I want to come off all my meds, but I don't want to give up all this stuff. It's like, okay, you're not going to come off your meds. And
I've got a pair of earrings for that person.
Yeah. You have to take those earrings, right? Or you have to shoot a drug. And so it's really a hard sell because I just recently I have several patients I sat down and I said, look, here's the downside to these injectables, right? And they go, yeah, I don't care. My cousin lost all this weight. I mean, I could tell you, look, you're going to gain all your weight back. And it's just like the mindset of the Olympic athletes. If I can make you win the gold medal, but you're going to lose 15 years off the end of your life, they go, okay, I'll take it.
I don't care. But they've got to, you see, everybody has to bump their own heads. And we've got to be there to pick them up afterwards. So many people have bariatric surgery, lose the weight, and then 5 years later, they're in my office saying, well, I regained all this weight, the surgery failed. Then I've got to pick them up and say, and help them along a journey of understanding that. However, Brian, along those lines, there's something that is also very, very important that most practitioners, unless they've had a problem themselves, don't understand. When we do eat something, we consciously and intellectually know we shouldn't. When we eat that piece of sourdough bread, even though we've done great on, and this happens to me because I am an addict and I still have these challenges. It is never, ever, and this is what practitioners don't understand, a conscious thought. It is never, ever a decision, a conscious intellectual decision that right now I'm going to eat this. It is an obsessive, compulsive, visceral feeling that drives us to do that. And that is why we are our own greatest enemies. And if the wrong stuff is in proximity to you, it's just a question of time before that visceral subconscious is going to lead you there. If you have distance from it, yes, you can still get in your car at 11 o'clock at night and drive to the store and buy the ice cream, but that distance protects you along the way. So what we tend to do is afterwards, after we've screwed up, after we've shot up with heroin, then we have the remorse and the guilt and the intellectualization of why we did this. And addiction is all about how good we are at minimizing, trivializing, and rationalizing a mistake to the point it didn't happen, then we repeat it. But don't ever think that you can preemptively think yourself out of that situation. That's why in addiction management, you crumple up the cigarettes, you throw them away, you pour the booze down the toilet. If I've got a pack of cigarettes in my pocket and I'm saying I'm not going to smoke, I'm just going to keep there to remind me not to smoke. That's ludicrous. Oh, I don't eat pasta. Only the children eat pasta in the house. I make it for them. I don't eat it. BS, of course you're going to eat it. Not today, but when life throws an emotional curveball at you.
Yeah.
The other concept in this regard is in addiction, all we care about is the immediacy of the high, okay? We are completely oblivious to the underlying emotional tension that is driving us to the fridge or the pantry or to the store. And a large part of the work that we do with our patients is, okay, now I'm standing in front of the fridge is open. Step back from that for 1 second and ask yourself, why am I here? And connecting with your emotions. Am I stressed? Am I angry? Am I exhausted? Am I frustrated? Am I bored? And if you can name that emotion and say, okay, when I'm bored, I'm going to go outside. When I'm depressed, I'm going to listen to my favorite music track. When I'm angry or frustrated, I'm going for a run. I'm going to do some weights. Have a response to the emotion, but in order to do that, you got to know what the emotion is. And most addicts, in fact, all addicts are disconnected. All they know is right now I need the high, but they're disconnected from the why. Because that's what we do. If I have a big fight with someone today and I come home tonight and I eat a tub of ice cream, it'll relax me. It dissipates the emotion, but it disconnects me from ever processing why I had the fight. That's why addicts are less effective human beings typically, because they are unable to connect with and solve tough emotional problems. All they're doing is using their drug for that instant gratification. If you go for a walk, the walk takes time and effort, but while you're walking, the emotional tension dissolves, but also you can connect with and process that fight that you had. Okay, I'm not happy about the fight. I've got to apologize. I've got to change my behavior. By the time you come back from the walk, 3 things have happened. Number 1, you're emotionally relaxed. Number 2 is you've got a game plan for dealing effectively with the issues or letting them go. And number 3, when you come back from that walk, that is an unconditional high. That self-approval doesn't have any negatives to it. And the key thing is to be focused on the effort, not the outcome. But when you eat that tub of ice cream, you've got to rationalize to yourself. You have to lie to yourself and convince yourself that that was okay, even though you're 300 pounds. That's
And
a
your
problem.
sugars are out of control. And that's when
By
you're
the way,
addicted,
yes.
you don't look at that. You don't want to see. And that's the thing. And getting back to the addiction thing, Rob, that's so important is last night I had a Zoom meeting. Every other Wednesday we do Zoom meetings with all my patients, whoever wants to come. The people who are struggling the most are the ones who don't show up. The ones who are there every week are the ones who are crushing it, right? And they want to help other people.
Brian, the alcoholic who doesn't go to AA isn't sober.
Yeah, exactly. And that's the thing is like you have to invest that time and you have to, and some people go back and listen to it. But I think sometimes you need someone to, like I alluded to at the beginning of this podcast when you talked about dopamine fast, just sitting there doing nothing for a day. When you were talking, I could feel the stress, and I'm not a stress guy, I could feel the stress. I was like sitting there for 3 days and doing nothing. Then when I go back, I'm gonna have to work for 85 hours a day. I might be running and I'm never gonna catch up again. And you think, why would life be like that? And when you talked about being more patient afterwards and being able to, write letters to people who influence your life, stuff we don't think about, sometimes just getting that pen and paper and sitting by yourself and saying, okay, I'm not happy right now. And at that point of my life, I wasn't happy professionally. loved my home life, but I was never there. So I can never take a day off. If I took a day off, it would take me a month. So what if a family member gets sick and I need a day off? I had 30 patients I had to put somewhere where I had nowhere in the schedule. I was already working through lunch every day. So when you start seeing that and reassessing and saying, okay, what really matters in life, right? Ultimately saying, hey, what matters? Is eating this cookie going to make me happy, or is going for a walk going to make me better in the long term, right? Not right now what I want. And I think it's so important that sometimes we just sit back and reassess, because why am I frustrated? Because at that time in my life, I was frustrated, but I didn't know why. And I was frustrated because my options in the standard practice was, okay, I could rush through every patient and just write out drugs, right? And get them in and out really quick and see a ton of patients. Or if I'm talking about metabolic health and trying to help that patient, it's going to take longer for them to see me. So either way, the patient's going to be mad at me because they're like, how come it took me 3 months to get in? Well, because I'm taking care of all my other patients and I have 2,200 patients, right? So now that I've cut down my patient load, as you've done, we took a pay cut, but the satisfaction, the enjoyment we both get passionate, as we get older about what we're doing, and we love it because we're making an impact on people. And so many doctors are just writing the prescription. Here you go. I got to be in compliance with the guidelines, and my patient's getting sicker, but I go home, at a reasonable hour sometimes. It's really a hard thing. And the practitioners are in a bad space because we're sick. We're going to die early. We die before everyone else because we're just so stressed and we take care of everyone else except ourselves. So I won't work out today because I got to see 5 extra patients,
Well, I think, Brian, you bring up such an important topic. And along with that dopamine fasting, but it really is about prioritizing self-care. So something I talk a lot with my patients about, and I'm going to ask you this question more for the people that are watching this to ask themselves the same questions, because this really defines self-care. And if you outsource self-care to instant gratification, that gives you that sudden high, that sudden emotional resolution without spending time with yourself. So let me ask you this question. You've got kids, am I right?
Yeah, 2 daughters.
Right. Let's take you back a few years. Let's make the daughters 3 and 5 years old. And you're flying on an airplane and everybody's having fun. And suddenly the cabin pressure goes down and 3 oxygen masks fall from the ceiling. And the girls are going, I can't breathe. What do you do?
Yeah, you put their oxygen mask on, right? You get it on them as quick as you can.
What would you do? What would you? You're giving me the theory. What would you do in practice? Your daughters are dying beside you. What instinctively would you do?
Instinctively, I think the first thing for me, I'm just saying what I would do. I would say, hey, let me grab those 2 oxygen masks, throw it on them, and then I'll put mine on next.
That's exactly right. So the point is that when you take care of other people, okay, when you put their oxygen mask on first, you're dead. Of what value are you to the people around you that matter the most, your patients, your family, if you're dead?
Yeah.
The oxygen mask. So the point about the oxygen mask theory will tell you, or they tell you on the airplane, put your own mask on first so that you're better equipped to help those around you. And whether it's dopamine fasting, having that reset from time to time, or just practicing the way you practice now, which is taking care of yourself first so that you're better able to handle it. I can see 20 patients in an hour. I used to do that. I lost everything. That's being selfless. That is where you're so busy taking care of others because you value, as an addict, the reward and the approval of others to bolster yourself. When you are feeling good from within, when you generate emotional well-being from within, yes, I love the results I achieve with my patients, but I don't depend on that for my own self-esteem. So because I have other internal mechanisms of taking myself, it's called being self-indulgent. I indulge myself with clean air and oxygen, so I'm better equipped to help those patients and to be objective with them.
And you can think clearly,
at the
and
same
you can,
time,
yeah. I mean,
no,
that's
and so understanding whether it's dopamine fasting or the oxygen mask theory. And so I ask that question of so many of my patients, and so many people justify eating crap and not going for the walk because they don't have time, because they're so busy caring for others. But if you don't have time for yourself as a priority, you're actually less effective at taking care of those around you. And a part of addiction management is to transform that. Do what you've done, do what I've done. The pay cut, okay, so I've got a big pile of money because I'm seeing 20 patients in one day. But if I don't have time to spend that money, if I die before I get to that point, what the hell is the point?
yeah.
And if
I think that's the
angry at my
perspective,
patients,
man.
if I'm using algorithm medicine because I'm on a treadmill, I'm doing a disservice to my patients, and my job satisfaction is gone. And like so many other doctors, we're burning out. I love what I do, and I'm doing just fine. And I know my patients and the public care about what we do. So my passion hasn't changed, but my passion for myself equals that for others. The only other comment that I want to make to you, Brian, is I tell my patients this a lot, is look, and this is so important about the trust we build with our patients, because they have to trust us that we're going to be there for them. Because if they've crashed and burned, and you come in and you beat the crap out of them like Weight Watchers does, oh, you cheated, you're terrible, they're never going to come back. And I think the key thing is that while I may be direct, I will never, ever be judgmental or critical of you. I am there as long as you'll have me to help you along a really tough journey. We're walking this journey together. I'm not telling you, you must do this, you have to do this. Let's hold hands and walk this journey together. Because
that's huge.
And walk him.
Yeah, and knowing that and saying, hey, look, we've all had struggles with weight too, so we know how it is. We know the game. We know what works and what doesn't work, and we have life experience in this. Someone who's been skinny their whole life has no idea, because they've never had the struggle. They've never had to try to lose weight. They've never had to try to get their lifestyle changed because they've been metabolically blessed, or they have muscle mass, whatever it may be. They may be a foot taller than me, like you, but it's those kind of things when you can really help a patient, when you could really say, hey, look, like you said, no one, when you wreck the car, you don't need someone screaming at you because you wrecked the car. You go, I know I wrecked the car. I feel bad about it. And so we already know we made the mistake. So how do we get corrected on that and getting back on course? We all get off course. How do we get back on course? And the longer we're off course because we're ashamed, the worse we do. And so, that's why it's like what you're saying is like, hey, you're direct. I know you're direct, and go, look, here's the data. The first time I met you, I'm like, who the hell is this guy? Right. Because you're like telling Gary Taubes, like, that you're reversing fatty liver disease in I know it's earlier than 3 days, but 3 days just with lifestyle change, And so you go, wow, it's amazing how, I'll tell you, when I see you, I go, okay, Rob, there's certain guys like Ben Bickman, there's certain people I know, Jason Fung, I know their integrity. I know what their motivation is. So that's why your April Fool's joke, when I saw him, like, oh my gosh, if Rob's doing this, there's got to be something to it, right? Me knowing what I know can be suckered in. And then I start thinking about it, I go, wait a minute, that doesn't make sense, right? So I think being able to critically assess, see what, and you and I have the advantage of being clinicians, not dealing with mice in a lab somewhere where they give them 500 calories a day and see what they do. We understand there's stress, there's life, there's social intervention, there's our addiction issues and all that kind of stuff. So some of these models are so crazy because you go, they're not dealing with getting laid off their job or getting locked down for 3 years and not being able to see a human face. These kind of emotional impacts on us. So when we saw that, so many people turned to alcohol and drugs and pornography, whatever it was, to get through those hard times because you didn't have that social engagement and connection, and building communities like you're doing. All these things that we're doing, it just works.
And I think you're absolutely right. Brian, we're not telling people what to do. They must do this, they must do that. We're helping people who have chosen to come to see us make better choices about how they are going to die. That, the one thing absolute about every one of my patients, we're all going to die. How we get there is our choice. And living longer it's a fallacy that's sold by the internet. We're all predetermined to live a certain length of life. If we read the perfect life genetically, there's a certain longevity. It might be 120, 130 years. We don't know. But what we do is we don't live longer. There's nothing you can buy on the internet that's magically going to make you live longer, even though they love to sell that. What we do is we subtract from how long we're going to live. And we all have choices to make in terms of what those subtractions are. If you choose to text while you're driving, you may suddenly shorten that life. If you choose to smoke, if you choose to do alcohol, if you choose certain things, you may suddenly shorten that life. At the same time, if you choose not to do those things, if you choose to invest in yourself from an emotional and a behavioral perspective, from a health perspective, you can maximize that level of longevity. So it's the absence of harm that I focus on, the reduction in harm, but it's ultimately your choice. If you choose to eat that sourdough bread, I'm not going to be there and chastise you for it. If you choose to take a statin, or if you choose not to take a statin, I'm going to give you the information, the pros and the cons, but same thing about texting, but you have to make that decision. The other key thing, and this is such an important aspect that people don't understand in the ketogenic space, early on, when you come off carbohydrates, there's a tremendous therapeutic benefit. Every day you're losing weight, your blood sugars are normalized. It's wonderful, you're getting better and healthier, but there's an inflection point where now you've reduced all the harm, and now you go from a therapeutic paradigm to a preventive paradigm. And most people fail or crash at that inflection point where they are no longer seeing external benefit.
The bells and whistles aren't going off at Las Vegas slot
exactly
machines
right.
anymore. Yeah.
But the point is, the absence of benefit doesn't mean there is no benefit. So I'll give you an example. If you don't text while you're driving, there's no measurable of the fact that you didn't die, but it's obviously a good thing. And I think a lot of our patients are already successful with a ketogenic lifestyle or a low carb lifestyle for a long period of time. And this brings me to an important biologic metric that I've discovered that you may or may not have seen yourself, is that once you get into that preventive mode, there is a slight expansion of what you are eating and you can eat. But there's two comments. I don't know what our time is like, but there's two comments. First of all, I am currently in a very ketogenic space. I've been carnivore for several months. I know that I'm in ketosis, I'm low carb. I'm currently wearing a CGM. And here's an interesting comment, because a lot of my carnivore veterans or my keto veterans will say, well, my blood sugars are up. So here's what happens in a healthy way of life. I eat typically once a day. I'm sipping on my coffee. But when you watch your blood sugars every 5 minutes, your blood sugars will tend to drift down, down, down. I often see myself in the 50s and the high 40s because I know I'm in ketosis. I can taste it, I can feel it. But at some point, typically for me, it's between about 47 to 48 and 52, 53 on my blood sugar. I suddenly see a spike in my blood sugar. And what happens is biologically, and this is the way the human body should work, this is a bit of science. The way the human body should work is the liver should be the source of blood sugar. It should not be your mouth, primarily. So what the liver does is it should recognize a certain low threshold of blood sugar and then add a certain amount of sugar to your bloodstream. So I'll see my blood sugar go up. Now
it's like a thermostat. It's a thermostat. Like if you get too cold, it kicks in. If it's too hot, it doesn't.
But it should kick in at a certain low point. And then what happens is that blood sugar rises a little bit, may go up into the 80s and 90s. Well, I've done nothing. I'm sitting here talking with you. But that is my liver and glucagon doing its job. Then what happens is I'll see insulin kick in and I'll see a sudden drop. So throughout the day, my blood sugars are going up and down. Now, the difference is this, because I'm in ketosis, I'm not hungry at all. If I wasn't wearing a CGM, I'd be oblivious to that. If I was only doing a single finger stick, I'd be oblivious to, I'd get upset. Oh, my blood sugar is 105 or 96. Why? I'm keto. Well, that is your body.
It's physiologic.
But because the key thing is, it's not about, a little bit of how high it goes, but if it's in below 110, I'm okay with that rise. What you want to then see is the sudden drop. So I would urge people to use a CGM. Even if you're a long-standing carnivore or keto veteran, use that CGM to see the natural biology. When I exercise, I'll see my blood sugar go up into the 150s. I'm not very fit, but yeah, exactly.
We both have ours on, and we've been doing this for a while.
It's the new Dexcom G7.
Yeah, you have to have a Dexcom because mine will alarm like crazy. If I was at your sugar level, might be listening to my alarm all day long.
So
it's amazing.
You switch your phone off. You switch your alarms off.
Yeah, you have to turn off your Bluetooth. Yeah, I know.
But
yeah, that's what you got to do.
It'll shout. But you know what? That little ding or beep is pride. It's like, hey, it's like a little check mark. It's like a slap on the shoulder saying, hey, good job. But the point is that a lot of our patients are upset. Our carnivore veterans, when their blood sugar goes up a little bit because it's a one-time measurement. You need a CGM to be able to see that. And that's something I've self-discovered. So I just want to put that out there, is that health is about when you produce insulin. And if you're producing insulin when your blood sugar is a little bit on the low side, rather than to manage excessive blood sugar, that is being insulin sensitive. That's one of the keys. So I just wanted to put that out there. That's kind of a self-discovery thing. I know there are other people out there that understand that, but that is the value of CGM biohacking.
And here's the critical thing I'll say, because I've heard so many people say they should be over the counter. All these people should have CGMs and their doctor can manage that. Here's the problem. They're going to look and say, oh, at 2 o'clock, your sugars went up high. You need some more drugs at that point, instead of saying, hey, what did you eat at 2 o'clock? What were you doing? Were you stressed? Were you fighting with your husband? Were you late for your meeting, whatever? So that's why they need people like us who understand the technology and that is going to be off sometimes, that we can make adjustments and say, okay, don't worry. That's a good sign. Like Jason Fung did for me when I first started. I'm like, crap, my sugars are going up every morning. He goes, oh, that's good. You're fat adapted. I'm like, oh, okay. Now I can tell my patients. And so, just learning from you, what you've had a huge impact, man. I mean, honestly, a huge impact on my life in a lot of ways. But the science of saying, hey, look, here's the science, and seeing all your old, photomicrograph, the electron microscope of the endothelium and what happens with high sugar, high insulin. All these things are such a contribution. Even at the time, you think this doesn't mean it. This is crazy. It's no one thought about it.
Let me just put one thought out there.
Yeah.
Diabetes is a clotting disorder.
Yeah, I think that's what we're going to see. I think that we're seeing that is that, when the clot thickens, that book,
Malcolm Kendrick. Yes.
Malcolm Kendrick. Yeah. And so there's a lot of stuff where we know inflammation is our enemy. So with this chronic inflammation of being stressed and tense and cortisol through the roof and all these things we're going through with hormone changes and all these things, that's why I'm saying it's this whole metabolic picture. Is not just say, some people say, here, eat page 3 or whatever, just eat this the rest of your life and everything's gonna be great. Well, sometimes you got to adjust that. And sometimes you're going to lose weight and you're going to get metabolically more flexible. Things are going to happen where maybe sometimes some of these people are going to, liberalize their carbs if they're a triathlete at certain times of their training in order to get their maximum benefit. But, it's really saying, hey, look, I mean, I look at it and say, look, life's not fair. I can't eat the same thing Ben Bickman maybe can eat because he's so metabolically healthy. So I've destroyed my body all these years of being a doctor. So you go, okay, now I got to get to that point. So it's going to take longer. And I think that the take home can be, look, it's going to take time. You're not going to plant a seed today and then you're going to have a tree tomorrow. You have to wait, and that tree's got to be watered. You got to make sure the environment's right, that animals don't eat it. And then sooner or later you got a tree. But we have to be able to say, okay, right now I just have a seed, but I know the future is going to be a tree if I do everything right. And so some of us, because you think if you're 400 pounds, it's hard to start. And you go, where do I even start? Like, gosh, if I lose 80 pounds, no one's going to notice, at that point. But you're getting healthier every step, and you're getting more self-confidence every step. And so I have some people who've done, you look at it and go, wow, what an honor to be a part of that process of someone. I have a guy that I used to take care of, was hooked on meth. He gained a ton of weight. He has a lot of emotional issues. And he came in, I go, look, I know you. Are you serious about this? Because you're going to waste both of our time. This kid has lost 48 pounds. He was just at the Dodgers opening game, and he's not eating the bun. He ate a Caesar salad. He did all these things right. He threw away the croutons, and he walked around Dodger Stadium 2 or 3 times while he's there. He walked up and down the stairs. He did all this stuff. And he goes, I had a blast. And he goes, before I would have 3 hot dogs with the bun. I'd have nachos, I have the ice cream, and I have, I don't feel like crap the rest of the time. He goes, I felt great after the game. He goes, and so when you feel that, I mean, like giving someone their life back or helping them get on the right track is so rewarding. And that's what we took a little pay cut for that, because there's more things, there's things that are more important than that.
I think, Brian, what you're articulating is this, and this is something that's fundamental to our way of practice. There are no endpoints. Diets are an endpoint. Okay, I'm going to lose 25 pounds. But in what we do, this is a journey of milestones. And the journey only ends 10 minutes after we die. Every single day, there is a new milestone, whether it's that 400-pounder losing the first pound, whether it is the guy that couldn't walk a quarter of the way around Dodger Stadium who's now doing it 4 times. This is a journey of milestones. And if you are continuously setting new milestones for yourself, new little objectives that you want to cross, you're continuously moving forward, and you're far less likely to go sideways or backwards when you are challenging yourself to go forward, not just dietarily, but also from an emotion management perspective. I know time is long. Do you have a few minutes just to talk about one?
Man, if you're here, this
Okay.
is gold for me, man. I'll take as much of your time.
You and I haven't talked for a while, so this is just another thing that we are seeing a lot. And you have that penny drop aha moment. Do you ever get people consulting with you that do not have a weight issue? They're not obese, they're not overweight, but they've got a bunch of GI problems. They've got names for them. They've got SIBO, they've got IBS, they've got GERD, they've got mast cell intolerance, they've got allergies to everything. And pretty much all the advice you give them, well, I can't, yeah, that sounds great, but I can't do this because I've got this allergy. And they've been to doctor after doctor after doctor. The allergist said, I have all of this. The functional medicine doctors said, I have all of this, and this is what I've got. They cleanse my gut, but the SIBO treatment. Do you have those patients that come in with a list of GI issues?
Absolutely.
And what is their weight typically?
A lot of times they're normal weight.
A lot of the time they're underweight.
Yeah, an underweight or normal weight. Yeah. I mean, well, for us.
And what I'm talking about is a BMI in the 14 to 17
yes.
range, okay? And this is something that we see a lot. Now, the challenge for us is each one of those labels. The one that we're seeing a lot now is something called Ehlers-Danlos. Okay, you've got, this doctor told me I've got Ehlers-Danlos syndrome, which is a connective tissue disorder.
Yes.
But Ehlers-Danlos has a specific diagnosis. Why don't we get the test? Oh, no, I don't want to do the test. So it's a very interesting psychopathology. And typically that's been going on for years, for decades, often starting in early adolescence. And more, I'm seeing probably on a daily or an every other day basis, somebody with some of this symptomatology. And there's 2 parts to this. Some people absolutely have those individual diseases. I've got IBS amongst other things. I've got this amongst other things. But when they come in with that symptom complex, and this is something that I'm working with, we have a psych nurse practitioner in our office, and it's so difficult for them to connect the dots because every doctor is focused on the somatic, on the bodily issue, rather than what root causes. What do those people typically have? And it's almost impossible to get them to understand this. What is the primary diagnosis?
Well, I would say, in my experience, I would say stress, anxiety, not sleeping. It does affect the mucus layer of the colon and the gut microbiome. And there's a lot.
Let's take that back a few years. What was the start, the origin point of this?
IBS, like IBS type symptoms?
Let's take it even. I'm talking about not someone who just says, tons of my patients have IBS. That's a carbohydrate issue. But I'm talking about those people who have that symptom complex of multiple 4-letter words. As I said, SIBO, IBS is 3 letters, but mast cell intolerance, addiction issues. I can't eat egg white. I can't eat and each one of those are plausible. But when they come in as a collective, that they utilize to defy every piece of advice you give them. And their BMI is low, not high. What's the issue?
Honestly, I think it's mostly emotional.
Okay, but what's the diagnosis?
That's my take. That's my take on it.
So here's
a lot of times we find it physiologic. And I'm telling you, Rob, this is what's blown me away. As a matter of fact, I'll tell you, just this week I had a patient. She had all those things. Her doctors, I read all of her history. Her doctors thought she was I'm going to have her on the podcast. They thought she was crazy. So they go, she's stressed. She's got anxiety. She's, she has an eating disorder and all this stuff. And then she went carnivore and all of her stuff got better. Her IBS is gone. Her bipolar is stable. Everything got better. Yeah. So, for me,
that's not the person we're talking about. Is somebody who is willing to do that.
She researched, she did her own work, and she came to me. I'm like, oh my gosh, right. You're a dream patient. Like, you get it now. Like, she knows where she's feeling better when she took out the terrible food she was eating, and the stress got better. And so, what's your answer to that? So
we are more and more recognizing that those patients have anorexia, bulimia.
Mm-hmm. Oh yeah, sure.
And the eating disorder is polar opposite to the obesity side. But because it happened 2 or 3 decades ago, nobody's collecting the dots. And the person that vociferously argues against that, even though all the elements are true, if you objectify this, if you write down a list of all their issues, and you have other people look at that, it's the obvious diagnosis. But you cannot, and this is the conundrum that I have. Just last week, we had 3 patients in our practice that all came in with exactly the same diagnosis. And because I've got a psych nurse practitioner, I've got a dietitian who's very astute, each one of them is consulted. And some of the folks, like that patient, the bipolar person who has all the stress and all the other issues, they go carnivore, they do fine. When they object to that, or they are, and it is the subtle flat affect control. It's a very interesting.
Yeah, exactly right.
And the worst thing you can do is tell them what you're thinking, because they run away. They don't want to hear that diagnosis, and they doctor chase. They go to doctor after doctor after doctor. I'll get books of information on these patients, everybody else's diagnosis, but nobody has been able or has had the intestinal fortitude. I was going to use something a bit below the intestine.
Yeah, I'm with you.
That is willing to tell those patients, here's the problem. And even when you do, so the question is, do you kind of know that that's the problem but ignore it because they can't see it? Or do you point that out to them, and the risk is they run away to somebody else who's going to help them with their eating issue, with their SIBO, rather than with their mental health issue? And it's a big challenge.
Absolutely. That's why I was getting to the emotional part, and that's so important, because even stress screws up the microbiome and the mucus layer and all this stuff. And so getting the stress and the sleep right and saying, okay, how's life? You're going through, because a lot of these symptoms come on during times of intense stress, going through a breakup or.
Right, but also their response, my response to stress is eat my face off. Their response is not to eat. And
exactly.
When you don't eat, if you think about prolonged starvation, or if you even think about prolonged fasting, more than 36 hours, I can tell you that, and everybody in the fasting space says, oh, you got to eat this, you got to eat this, you got to do. Nothing works. When you've gone longer than 36 to 48 hours, expect to have the shits for 6 hours after you've eaten. Expect to have that GI intolerance. Well, if that's every day, if you have that GI intolerance every day because you're not eating, then of course you're going to focus on your gut. If you're eating lettuce leaves all day long, or eating a very, very super restricted diet, like a lot of anorexic and bulimic patients do, but mostly the anorexics, then these symptoms, the things that they develop labels for, are inherent to the concept of not eating, just like people who do fasting happens. But we know when we fast, we're going to expect to have the shits or whatever it is afterwards. So we know that we need to stay at home when we break our fast, or at least I do. And that's an expectation. But if you don't expect it because you don't realize how little you're actually eating, then you focus on this new discovered excess mucus, SIBO, IBS, all the irritable bowel stuff, or all the bowel which comes from not eating. And then when someone says, well, the start of this was the fact you didn't eat. And why didn't you eat? It wasn't intentional fasting to get healthy. This was not eating as a bizarre form of psychological management, just like cutting.
And control. Control. And
exactly
right. I think, Rob, too, is that when people are starving themselves or fasting, they get this ketone rush where they get a piece in that. So
absolutely,
they're getting a physiologic response.
Exactly. So what a lot of these people that do the fast when they're emotionally challenged and they don't eat, they get into ketosis. They have that ketone high for a little while.
Mm-hmm.
So the only message I'm putting out here is, having self-discovered this in my own practice, and I was naive to this for years, now it is slapping me in the face. And at least as practitioners, we need, without obsessing over it, we need to ask that question. Is the person I'm seeing in front of me with all these GI issues, now they could have Crohn's disease, they could have ulcerative colitis. So it's a diagnosis of exclusion, but at the same time, once all of that has been done, they could have tick bite, they could have Lyme's disease. Yes,
parasites,
all of those things need to be excluded. But once they have been, then perhaps we need to think more astutely, because I see so many people with an obvious diagnosis of anorexia who've been to doctor after doctor. They desperately want to get healthy, but they want their gut to be healed. And every doctor is throwing pills, powders, and potions at them to fix and test
emotional
their gut.
Yeah, that's absolutely correct.
Not eating. Does that make sense?
Absolutely.
So,
Absolutely. And plus, Rob, the other thing we would see in that same patient is having super high LDL cholesterol when you have anorexia, because your body's panicking, kicking out every fat cell that it can into the bloodstream. So to say that your diet, if you take that person and you put them on a carnivore type diet, their LDL normalizes, or it comes way down, because now they're getting nutritional, right? They're not losing weight anymore and they're putting on weight. So that's the other thing is, that you and I have learned over time is like, okay, when you first start to a low carb diet, when you start losing weight, your liver test might go up for a while because you're mobilizing fat. Your LDL may go crazy for a little while, but we have to stay the course of time and follow it and say, okay, don't worry. As a matter of fact, I do Sika testing, looking at body composition, and a lot of my low carb people, when they first start, they'll lose muscle mass on the scale, but they're not losing muscle mass; they're losing fat volume in their muscle, and they're getting more lean, and they're feeling great, and they're not losing muscle; they're working out for the first time in their life, right? Yeah. So there's so much like that, and then maintaining, and it's just what you're doing is great stuff. So I've got to ask you, Rob, since I don't want to keep you all day, man, anytime you want to come back, I would love to have you come back and we talk about exercise physiology with a low carb diet, what we're seeing, all these things that people think they need to carb load. What do we see clinically? I have some great data on that, and I would love to hear your stuff. And I know I heard one of your talks. I mean, I think I might have been in on the discussion, but that when you put on your running shoes, your sugars go up before you run, before you do anything, because your body says, oh, I'm going to give you some extra sugar, to get you through this run, which is amazing when, the more we're learning how amazing the body is, and so I have to ask you, what's life's best medicine, first of all, and then where do people track you down and find you when they want to get
right. I'm going to answer that question, but just before I do, I want to put a plug in for a textbook that's actually coming out in this month in April, or shortly be released. It's called Ketogenics. It was edited and coordinated by Tim Noakes and the Nutrition Foundation. There were 62 authors. I've written 3 book chapters. So many of these questions will be answered from a science reference basis in that textbook. I've learned so much from those folks. So I just want to put a plug in for that.
Yeah, it's great. I got to co-author one too. Yeah, it's amazing.
Yeah, so it is going to be, I know you're part of that. So it is going to be such a useful tome as a foundation of thinking, and really has the science behind the discounts and counts in a lot of our beliefs. So for example, this whole anorexia thing, I wrote a book chapter on autism spectrum disorders. All of those are based upon the science behind this and the use of ketogenic diets to avoid or treat some of those issues. So I just want to put that plug in there. In terms of what floats my boat, what gets me going, there are 2 parts to this. More and more, I float my own boat. And the more I can rely on internal emotion management and internal highs that I generate through what I do, and through what the important people communicating with my wife, with guys like you. This wasn't a science discussion. It was almost a little love affair, because I'm on a high right now because I've communicated with someone that I love and trust. And learning to love and trust 2 or 3 or 4 people around you that benefit you. So relationships, having a better relationship with myself, that is what drives me. And then allowing what's evolving and happening in me, in my body, in my brain, in my emotions, to be translated to my patient population, having them also see the benefits and get healthier and understand that they're empowering themselves. That's what gets me high. This is a voyage of self-discovery. And every time you and I talk, and we should do this more often, it's new milestones of discovery along this pathway. And that is what I love. That's what drives me. That's what I enjoy.
Yeah. Ditto. I mean, it's the same. I get energized when I see you. When I knew you were going to be on, I had a nightmare last night. I slept through our interview. I'm like, oh crap, I missed it. So, I set my alarm twice today to make sure I was up, because, it's really, really important. And what you have to offer is huge. So I want as many people to be exposed to what you're talking about, your science, what you're doing clinically. You're putting it all together. And so there's some great researchers, but they do research. They're not seeing patients. And there's some great clinicians, but they don't look at the research. And I think what you're saying holds true, is that we have to be able to learn from each other and go, Rob, what are you seeing? Brian, what are you seeing? And we can modify what we're doing, because a lot of stuff I've learned from you, I've implemented to my practice now, and I can help people because I go, oh, Rob said this one day. I'm telling you, Ben Bickman, Jason Fung. I mean, I use a lot of your stuff because it's the best information out there, and it's helping people. So it's like, hey, we don't have to have the pride of saying, I have to come up with all these discoveries, saying, hey, look, what are you doing over there in Texas? What are you doing in Nevada? What's working? What's not working? And then we can adjust and be better doctors and clinicians. And I know we're trying to get a group of doctors that are like-minded that we can kind of, really, really impact lives and help people and really save the medical system. If everyone's dying of all these things, and like you said, Rob, we're designed maybe to live to a certain age, and we subtract from that based on what we're doing. But the more important thing too is like we want to live our life up to that point when it's that last breath, and not be stuck in a nursing home looking at a wall when we're 60 for 20 years. Even though we live an extra 20.
I want to wake up dead one day, Brian.
Yeah, that's what we want to do. That's our goal. It's like, hey, you die and you go, okay, I did my impact, and then it's what we leave behind. So no, I just want to
thank you. I don't want to be sick. I just want to die. That's the goal.
Yeah, that's all right. We just want to die one day and you're good, however that may be, and with as little pain and concerns as possible. But part of it is living our life right, and you really hammer home the point of having this overall balance, having your, where do you find your peace? Where do you find your purpose in life? And, can you look long-term, not just what you want right now in this second, because we're in a microwave society where we want it now. I don't have time for you to wait to cook that chicken, right? Don't put it in the oven, put it now in the microwave because I want it now. But it's gonna be a better product if you can smoke it and barbecue it or whatever, right? So yeah, but Rob, hey, how do people track you down that want to find you?
So on all social media, YouTube, TikTok, Instagram, I'm Carb Addiction Doc. And then we have a gateway into our practice. And if you don't have this, Brian, I would urge you to do this for your practice. It's called our bat phone. And it is a cell phone that has a number. The number is 561-517-0642. And you can call that number and leave a voicemail. You can WhatsApp to that number. You can text to that number. And then I've got one person in the office that monitors that line and then gets back to you. If you leave an email address, if you want to text back, if you want to WhatsApp back, and we can then set up visits with you. So just that bat phone has helped our practice tremendously. Because I think that the big difference between conventional doctors that rely on other doctors referring patients and the space that you and I work in, which is, I call it the DTC space, the direct-to-consumer space, where people want to come in to see me. They're not being forced to come in to see me. That's how they enter the practice. Of course, we take referrals, but the ideal is for you who've already chosen this pathway to say, okay, I want to come in here. A little bit like AA. AA doesn't go out and recruit alcoholics. Every alcoholic knows that AA exists. And when you realize, oops, I am an alcoholic, I want to quit drinking, I want to rebuild myself, then you go to an AA meeting. And that's kind of how our practice works. But that's that back phone, 561-517-0642.
Bob, thanks so much. Yeah, and what you're doing is critical. I mean, it's such an honor to have you on always. I get so excited to talk to you. And I just, when we can spend time together, outside the podcasts and conferences and all that stuff, it's always awesome, just have a great conversation about life and what matters and all this important stuff. So thank you for your influence on me, my patients, making me a better person, a better clinician. And everyone listening, this is a gold standard. This is a bronze, or not bronze, what is it? A platinum episode. Like always, whenever Rob's here, like they're the best episodes. If you go back and listen to Low Carb MD, he helped get us off the ground. And really had me question things. We actually had a little bit of a debate, and I learned my lesson on the first one, whether carbs are addictive or not. And he convinced me, yes, they are. And so there's a lot of things that we're learning. So I would say, be kind to yourself, be kind to others. Don't be your worst critic. Give yourself a little bit of a break and just learn a little bit here and there. And some things may sound crazy to you, but say, let me try it for a couple of weeks and see what happens. And then you'll start understanding, if you can get your doctor to write you a continuous glucose monitor. If they won't, guess what? Rob and I are here to do that. Tro, all these great clinicians out there are really, really helping a lot of people. And we want you to be part of that. So, again, be kind to yourself, be kind to others, enjoy life. It's okay to smile. It's okay to sit and just look at the ocean every now and again. We're all so busy. And if this is hitting you a little bit, trust me, it hit me too. And I realized I don't have downtime at all. So figuring out, hey, I got to make this happen. I got to schedule this in, these workouts in, and take care of yourself, because no one wants to be a burden to their family down the road. No one wants to be a burden to their spouse. And we want to, just like Rob said, wake up dead one day and enjoy the journey. So enjoy the journey of weight loss or whatever you're trying to accomplish in life. And Rob, do you have any closing for us, man?
Yeah, I think the key thing is continuously question why you're doing certain things. The why word is so important. And then the second part about addiction management is Try not to be perfect. Try to be comfortable with your own mediocrity. You're going to make mistakes. Learn from them. Don't beat yourself up with them. You didn't cheat. You relapsed. You made a mistake. Why did I make the mistake? And the next time, how can I do it differently? If you're challenging yourself and creating new milestones, you're moving forward. And life is a journey of forward motion.
Awesome. Thank you so much.
Thanks, Brian.